Hello and welcome to another edition of our EMG cases called Signal Sleuths, as we are trying to be detectives and figure out these cases. My name is Ken Vitale. I'm a physician here at the university. I do a lot of EMGs for orthopedics, and here I like to review some interesting cases and share with you what I did well, what I did wrong, what I could have done better, and well, I want to know what you do in EMG, as it is a very complex field with a lot of nuance, and would love to know and learn from the community as well. So let's get started. Here we go. This is case number 4. And again, as usual, we just start with the EMG data and withhold some of the clinical so we can kind of put our detective hats on and try to figure this out. So we start out with, well, straightforward sensory studies here. We have median and we have ulnar, and, well, not much cooking here. Next slide here, we now have a thumb, median and radial sensory latency studies. And if you pull up my point here, if you factor in the temperature, that's going to be normal. There's certainly no latency difference when we are assessing things in a little more detail for some other pathology. So that looks good. And then we have median and we have ulnar motor, and those also look good. These are the waveforms in case you were curious. There was certainly some motor artifact going on there. That happens, but other than that, that's it. And then we have some hand EMG muscles. You can pause it if you're interested, but pretty much everything is normal. So what the heck is going on, right? This is completely boring. I wouldn't be presenting this case unless there's something else cooking, and trust me, there is something cooking. But this gives us a chance to review some very important things when we have someone that comes in and we're doing a lot of hand studies, as is this case. And this is a really good bread and butter review for some of the learners out there. I do have a lot of students and people that are just starting out with EMG and want to know some of the core stuff, and this is a good case to illustrate this. We could be looking for carpal tunnel because of the median sensory studies. We could say, if we're looking at sensory to the thumb, also that could be carpal tunnel. We could also be looking for plexopathy. I have another case a little later on in this series that dives a little more into plexopathy, so I'll withhold some of that talk for now. The other thing is, maybe we're repeating this because there was an outside EMG, and what a great electromyographer said to me, well, said to all of us at conferences over and over again, is, what do you know about every outside EMG? Well, it's wrong, right? It's something's off. You got to repeat it. And actually, we found that to be the case quite a bit. EMG is a very user-dependent test, and we don't know what they were looking for. We don't know what their thoughts were. I certainly have a set plan based on the history, the physical, correlating imaging studies, and you want to build out your EMG to look for every possibility you want, and maybe they are looking at something specific on their EMG, and we just have to repeat it. So if you saw in the prior sensory studies, there was a conduction going across the carpal tunnel. We did latency at the wrist and then another latency in the palm. Does anyone do that? Some people skip that. I did learn it from kind of one of the OG electromyographers of the day, and they said, hey, absolutely, why wouldn't you do it? You have 14 centimeters at the wrist, 7 centimeters at the palm. You can get a conduction across the wrist. How about this? As this picture says, they are using index finger. I use the middle finger, long finger, instead of index finger. Does anyone use that? We find that index tends to have a little bit better sensitivity. The long finger has more sensitivity. The index finger actually has a lot more anatomic variation. We find this in plexopathy studies too, which is why with a typical plexopathy study, see if I can do this right with my hand, we want to do the thumb, the long finger, and the pinky as a screening for upper, middle, and lower, or superior, middle, and inferior trunk. It is a better assessment than the index finger. So that is why we measured conduction across the palm and why we use the third digit instead of the second. You could also say maybe I'm looking for neuropathy by doing different nerves in the finger, trying to pick up some area where there's prolonged latency. Again, would you call that prolonged latency? I wouldn't. I would call that temperature correction, and that is totally fine. Now, let's dive into the whole carpal tunnel world. Probably the most famous one that at least most people that I talk to use is the Robinson index, if they are going to do more detailed carpal tunnel studies. You probably know all this, but if you don't, this is a great review. Ring finger 14, thumb 10, and across the palm 8. and then the latency differences drop down accordingly. We are going to, oh, I don't have a slide on that, but it's 0.5, 0.4, and 0.3. And you add that, summate it, and if you get to 0.1, then you, sorry, 0.1, if you get to 1.0, or actually 0.9 in some of the studies, then we have a positive combined sensory index. I found this picture that is pretty wild. Just do all the fingers at once. Sure, why not? Do antidromic and orthodromic. This looks possibly like a stimulation, but that could also look like a little bar electrode that you do if you did an orthodromic. Problem with doing endless tests for carpal tunnel, eventually your, well, false positive rate is going to go up and you have to stop at some point. If you x-ray your entire body, you are going to find a positive finding somewhere that might not be giving you issues. And there's this great, oh, my face is in the way here, but as you increase the number of tests, you are going to increase the chances of getting an abnormal, incidental, asymptomatic finding, and you're going to muddy your test. Also, clearly, you can only go to a certain number of billable nerves before you're going to get dinged or flagged that you're overdoing it. So you certainly don't want to do it. The nice thing about combined sensory index study is that it brings your false positive rate right back to a normal, quote unquote, level of less than 3%, which is what you want. You also don't have to worry about temperature. You don't have to worry about age or anything like that, which is why combined sensory index testing is great. So thank you to Larry Robertson. I've met him at a couple of conferences. I encourage you to go to him if he's ever talking. He's a great resource. So what else is out there for carpal tunnel? Well, there are inching studies. If you know this for ulnar nerve, there is inching that goes across the median nerve through the palm. They're a little harder to do. It's harder to kind of track that pathway since there is a lot of variability and variation in terms of the anatomic pathway for the median nerve. You can do motor comparison studies, and what's out there is at least a 1.2, but 1.8 tends to be a little bit more confidence in terms of median to APB versus ulnar to ADM for your latency difference as another way of diagnosing potential carpal tunnel. Usually we do that if there are just no sensory values because it's such bad neuropathy that all the sensories are out, then you can move to motor. But the more advanced one related to that is the second lumbrical interosseous study, which is really nice and has a lot more, well, confidence and power in studies. And I've largely switched to this. I used to do this years ago, but now pretty much I just do this. You normally get a much smaller value anyway in terms of your amplitude differences, but we're looking for the latency is what we're looking for. If the median has a bigger latency, then you're going to have a positive test. So here's a little example of it. You stimulate median nerve, right over here you stimulate at ulnar nerve, and you're either recording at the second lumbrical for median or at the interossei for the ulnar. And as said here in these studies, if you have nothing, you have no median sensory, if you have no median motor at the APB, you can still localize and say, yes, this is a median mononeuropathy, this is carpal tunnel, even in severe cases, because even in really bad cases of severe CTS, about 75% of them will still have that waveform, which therefore translates into, well, these are some viable fibers that might make the patient get a benefit out of surgery. If everything is just completely shot, a lot of times our hand surgeons don't want to touch them because, well, what is there to recover? What is there to operate on? There's nothing. But with this, we can actually say, yeah, there are some viable fibers. They may recover some function, and maybe you might proceed with surgery. A couple more here. If you've ever come across these kind of landmark famous studies out there, this is where we get the famous 10% of patients with clinical evidence of CTS have absolutely normal nerve conduction values. And why? It's because it's intermittent transient compression. There is no clear demyelination. It's just a little bit of transient compression, and you're not going to get any prolonged latency or axonal findings during nerve conduction studies. It's basically because there's just transient ischemia. There's not enough of damage that is irreversible and therefore becomes detectable. It is transient and reversible. So this is why we have some cases of completely normal nerve conduction, and yet they have very obvious clinical signs of carpal tunnel. Here is another study out there that we start to review, and we're really diving as far in as we can go with carpal tunnel. When we have early carpal tunnel, routine nerve conduction studies are usually pretty normal. Sometimes you can look at the snap duration instead of just purely latency, which is a neat study that's out there that is starting to gain some traction. It was published during COVID, so it didn't really surface on a lot of people's radars, but that's a neat one. If you're starting to look at your cases, you might find that some of these normal patients that have CTS do have a longer duration. Another point of contention related to this is which nerve you test. So if you get a normal case of CTS and you tested the index, but if you went and then tested the middle finger or long finger, that might be involved, or you test the thumb, that might be involved, or the ring finger. Which one are you testing? You might get a normal finding or an abnormal finding. The index, in terms of topography and anatomy, is more posterior medial and centrally located. It's a little bit farther away from the site of compression. The thumb seems to be another area in terms of anatomically closer to the site of compression with carpal tunnel. So that's another reason to check the thumb, which is why I love doing the thumb when it's carpal tunnel, and it doubles for plexopathy. How about this? If anyone can recognize this, well, obviously it's an ultrasound, but if you've been doing this a lot and you can look at this, you recognize immediately saying, oh, that's a bifid median nerve. Got it. When you have a bifid nerve, you might not see abnormalities, a false negative, depending on where you are putting the stimulator over the nerve. You might not be getting the full ulnar or radial branch of the bifid median nerve, and you might get a false negative, which is why I like to incorporate ultrasound, especially on my NCS normal but clinically positive carpal tunnel case, because it's often going to be a bifid. I've seen so many bifid median nerves. I didn't realize the incidence was so high until I started doing ultrasound. Rounding out this carpal tunnel discussion here, hand laborers, people that are doing a lot of hand intensive work, they're all going to be positive. So you really want to up your latency in terms of your threshold to call it abnormal, because people that use their hands are just going to get higher incidence of prolonged latency. Same thing with diabetes or peripheral neuropathy or diabetic peripheral neuropathy. A similar situation here, your upper limit of normal, you want to change if you really want to be concise. Precise. These studies are getting a little old though, but they still stand true in a lot of patient populations. So something to be aware of in carpal tunnel. Anyone ever wonder why conduction velocity in the forearm is often slowed in cases of carpal tunnel? Well, this has been looked at, which is kind of a neat thing. It's found not due to conduction block, but retrograde axonal atrophy at the wrist. The traditional thought was that it was conduction block for the larger fibers. When they've done studies on this, apparently that is not the case. So that's a neat little, well, I don't want to say trivia, but it's sort of EMG trivia, because it doesn't necessarily impact our treatment or management, but at least it's an explanation of why we often get conduction velocity slowing in the forearm in cases of carpal tunnel. Couple things here with carpal tunnel surgery. This is something I get all the time. As I work in an orthopedic clinic, we have a lot of hand surgeons. Following carpal tunnel release surgery, motor amplitudes still are often reduced just because of post-surgical edema. It can persist for a few months and it resolves at about 6 months. There can be the argument made, why are you going to even do EMG after surgery? They're supposed to be better. But if you are doing it and they have low amplitudes, you should expect that, and don't say, oh, this is, residual compression, you got to do another surgery. That's not what you want to say. Sensory is kind of a similar thing, can take even longer. So we usually draw the line at about 6 months. It's kind of similar in the spine world. You want to wait about 3 or 4 months after surgery to detect a potential new change on EMG when you're doing needle EMG, in terms of what's chronic and a background versus what are new changes with a patient that comes back after having spine surgery and they have new symptoms, new radiculopathy symptoms. You don't want to do the EMG 1 month out. You're not going to see any differences. Same thing here. In terms of carpal tunnel release, there's a famous, I think it was the UK by Bland, a 1 to 6 severity scale. Usually, if you're going to have successful, which is considered 70, 90% is considered successful by hand surgeons, you're usually going to get at least a 2-grade drop in that 1 to 6 scale of improvement. If you're, as long as you're not a grade 6. If you don't improve those 2 grades, that is more suggestive of, well, inadequate decompression. Actually, that should say decompression, not compression. Residual compression or inadequate decompression. Um, uh, Correlating to, clinically persistent rather than recurrent symptoms, which is kind of a neat thing. And if you're only doing it for the sensory latency findings based on these studies, again, similar to the last slide, please don't expect improvement immediately and wait to do your repeat EMG. So this we come across quite a bit in an orthopedic practice on patients that have continued symptoms after carpal tunnel release. All right, let's dial it all the way back to the case, right? That case so far is completely boring. I wanted a chance or more an excuse to review some nuts and bolts carpal tunnel because we get so much carpal tunnel, probably the number one most common thing that we get in our practice here. What is going on in this case? Well, we're going to blow right through this really quickly. It's pretty fascinating, but really, there's not too many nerve conduction problems here. This is a 60-year-old female, had left hand discomfort when she was carrying a heavy bag. Kind of a vague and dull aching, right, in the palm and into the index and long finger or middle finger. That kind of sounds like carpal tunnel, right? Later in the day, put her hand on the toilet seat to push off and sit up, and quite literally said this, my hand exploded. Exploding sensation in her hand. It felt like my hand exploded and burning and radiating into the index and middle finger. Wow, that kind of sounds pretty traumatic. That is a lot more burning and numbness and neurogenic symptoms. That's kind of a very hard to find a picture of that on the internet, but extending at the wrist and pushing off your hand off the toilet. Not quite a foosh, but in a way, kind of a foosh type mechanism. Had a lot of left hand pain, decreased grip strength. When they were seen by primary care, I did not examine them, and the EMG was ordered, and that's how they arrived. So is this a case of traumatic median neuropathy, right? This is why I was reviewing all these carpal tunnel stuff, quasi-related to this case. That can happen. People can get a traumatic median neuropathy. It's usually with a distal radius fracture, or if the cast is too tight, but that's usually a slow, delayed onset. This was fairly abrupt, just pushed right down on it. And yeah, I guess in theory, like if you come right down on your medial elbow, you can get ulnar neuropathy pretty abruptly. Maybe you can get median neuropathy the same way. If you do have a traumatic median neuropathy, usually with a distal radius fracture, it's usually more axonal than demyelinating. It's a pretty nasty injury. The median nerve gets all swollen. Heck, you can even put in, people used to do this, Wick catheter pressures to measure the carpal canal pressure. Not really done anymore. But this patient just said, all right, I'm going to get up and push their hands off the toilet. That is quite a foosh type stressful event to get that traumatic of a median neuropathy. And the median nerve is actually fairly well protected between the scaphoid and pisiform there. Maybe something else is going on here. And sure enough, the patient started to note that after that, they started to get a little swelling at that wrist. X-rays were ordered, and they found a carpal boss, which is right there, not necessarily related, but primary care said, "Oh, it's a wrist injury. All right, go get your test done." Now, you probably know me by now in terms of these case series. What do you think I did? If nerve conduction was normal and EMG was normal, yeah, of course, I did the ultrasound. And guess what? Yeah, it was normal. This is still our more portable ultrasound. It's not the greatest resolution, but there's the median nerve at the wrist, not enlarged. There's the median nerve at the forearm, not enlarged. And here's on the ulnar side of the wrist, there's the pisiform right there with the posterior acoustic shadow. There's the ulnar nerve and the ulnar artery. Really, nothing doing. But when you actually examine the patient, and I didn't because they were in primary care, when they came to me, they were already there for the test. All you need to do is move a little bit distal into the palm. And if you move your probe a little distal into the palm, oh, we got something going on here. It's a little bit hard to see there, but that is quite a nice, large, hypoechoic, or really arguably anechoic mass sitting in the palm. This is why we love ultrasound. If all you had was nerve conduction and EMG, this is a normal case. The patient leaves. That's it. You would not pick up on this. So how do we quickly evaluate a mass on ultrasound? First, right, when we're writing a report, is it anechoic? Is it hypoechoic? Is it hyperechoic? This is largely anechoic here, but you can argue there's some echoic material there. Is there posterior acoustic enhancement? Does it get brighter right there? If it does, that means increased transmission flow, transmission of the ultrasound beams, and then things concentrate here. So it gets a lot brighter right through the liquid mass, which means this is water or a liquid of some sort. Is it compressible? When you squeeze on it, did that compress from here to here? I'd argue not much. Put on Doppler, and this is where things get fun. Oh yeah, we have clear Doppler flow through this part, but almost right down the middle, there is no flow on this side. That is suspicious. If you've ever seen this before, this should kind of trigger you to know, okay, I think I know what's going on here. We flip it longitudinally because ultrasound, you got to get transverse and longitudinal views. Again, there is flow, and you can track this back to which, well, vessel this may originate from. Again, you can see flow here, but underneath it, there's some lack of flow there, and over there. This is the window, so things get cut off right here in terms of the Doppler. So we are not observing flow here or here just because we're not in the window. This one tracked backwards to what I presumed was the ulnar artery. It very clearly had pulsatile flow, which means it's arterial, and it's not entirely filling. So you can argue, what's in that? Is this echoic debris? What the heck is going on? Can we make sense of this? Can we put a reasonable report and send it to our referring providers and sound like we know what we're talking about? Well, this is what I pulled this from the report. It's hypoechoic / anechoic mass, posterior acoustic enhancement, consistent with fluid-filled mass, has a pretty large cross-sectional area. If you've been doing ultrasound, that's a pretty big chunk there. It was relatively compressible. A ganglion is often like rock hard. This did have some degree of compressibility, but once you put Doppler flow on it, yeah, okay, this looks arterial, not venous. And on longitudinal views, we can track it back to the ulnar artery, which did have normal flow and compressibility like a normal artery. This one did not compress that much. It was a little bit maybe, but not much. And this is, yeah, where we go when we see a partial area of no flow and a partial area of flow, especially right down the middle. Could this be pseudoaneurysm? Dissection would be pretty darn acute and usually severe. Pseudoaneurysm can stabilize to a certain degree and not continue to dissect down and become an emergency. That can be a stable issue. So I was kind of leaning towards pseudoaneurysm just because it's often more stable than dissection. No, this is not from the case. That's just a picture. Nerve conduction studies are pretty much normal. Median nerve is normal. If you're into delta cross-sectional area, normal. So what do you do now, right? This case is just sitting in front of you. What are you going to do? Well, are you going to do MRI? You can do CAT scan, right? Angiogram. These are all different things you could do. Well, we went to MR, and sure enough, I don't know how well you can see it, right there, mass, right there, mass, and right there on each different view here. And what do we got? Distal to the hook hamate, around the fourth metacarpal, lobulated and heterogeneous, on the ulnar artery. Yes, I got it right. I'm lucky, happy. Swirling appearance with pulsation artifacts. That looks like blood, so they felt it was partially thrombosed pseudoaneurysm of the ulnar artery in a decent size. So what do you do with this? Do you leave it alone? Do you watch it, close monitoring, watchful waiting, or do you dive in? Well, you got to get a little more info on the vascular anatomy. So then you do have to go to CT. So this is becoming expensive, but this is worth it because we need different information from each of these tests. Found out from the CT, right? Superficial palmar arch, predominantly supplied by the ulnar artery. Once we get to the deep arch here, it was much smaller in this case and predominantly supplied by the radial artery. And we found yes, partially thrombosed aneurysm, immediately distal to the takeoff of the common palmar digital arteries, supplying mainly the fourth and fifth digits, and then proximal to the takeoff of the artery supplying the third digit, and that's often why she had the symptoms in the third digit. And this, some people talk about the hypothenar hammer syndrome in this case. I love video. I hope this is gonna work. Radiology does some pretty cool stuff. That's the angiogram filling everywhere, and you can see there's clearly a large collection of dye that should not really be there. And there we go. I love this 3D rendering that they do. There it is right there in all its glory, sitting there in the palm. And of course, radiology wants to show off and do the rest of the arm. Our hand surgeons do not need to know any of this. They want to know what's going on right there. But you can do this really cool um, imaging with 3D. I love that 3D. So this is a case of superficial palmar arch aneurysm. It often originates from the ulnar artery. It supplies the thenar and the rest of the muscles there, as indicated. It's pretty darn rare, and due to trauma, sorry, my face is in the way there. Patients can often get a pulsatile mass, pain and swelling. And well, in this case, which led us to the EMG, dysesthesia and numbness, because you're not getting a good vascular supply anymore. You can get ischemia like any other vascular issue, and that can become a problem. You can get nerve problems related to the ischemia, and there you go. So this patient had excision, ligation, did very well, had no problems. Immediately, hand improved. It's kind of funny that she made her way to EMG for this case, but she got to the hand surgeon and did great. And even at 1 week later, she had much better recovery of her grip and was very happy. Allen's test, if you remember that, good flow. So radial and ulnar are doing pretty well. There's a picture of the Allen's test there. The ulnar, it made it. It's still in recovery, but it made it there. My head is in the way again. This is a classic example, if you ever look that up, about just how well and poorly perfused the radial and ulnar side can be with a potentially positive Allen's test. So, yeah, what is going on here to summarize? This can be, in theory, mistaken for an immediate or traumatic carpal tunnel, especially if it's a smaller aneurysm. They might not have as many, blatant, urgent symptom presentation. If if they have obvious swelling and a pulsatile mass, that should be a pretty clear hint. But a lot of times primary care might not examine this area so well, and if it's small enough, you might not find it. If you are feeling a mass, lipoma, fibroma, Dupuytren's, that's another thing. But you better, have a low threshold for testing, high index of suspicion for a vascular etiology if you are not doing ultrasound. If it's small enough, it might not yet be appreciable in terms of the pulsatile nature to it. But usually you need multiple imaging to get to your answer. Doppler really helped in this case, not EMG. I'm glad we were able to get her where she needed to be in terms of MRI and CT, and then seeing the surgeon. So pretty neat case here. As I do in all of my EMGs, what could I have done differently? Yeah, I did not warm up the hands. You saw them, they were 26 degrees. That's no good. At least I did part of the Robinson index testing to potentially obviate the need for that. Of course, I did ultrasound, and could you argue, should we have skipped the MRI? If we did the MRI, should we have skipped the angiogram? The answer is the hand surgeons, at least here, usually want them both because they give different info. Yes, you could make the argument that someone could have paid a little closer attention to the hand and then expedited a more vascular workup and did not need to do the EMG, maybe did not need to do the X-ray, right? Some people, they come in, they're just here for the EMG, you immediately proceed with testing and send them on their way. You might not even examine their hand. In this case, it was pretty obvious that there was a pulsatile mass. But some people don't do that. This is why we often like to, right, repeat, do your own H&P for every EMG case, and you'll help to clear things up. So hopefully you got something out of this case. I know this was quite a long one compared to my other ones. Let me know if you have any ideas, thoughts, comments. I would love to hear from you, and I'll see you in the next one.